So let's review slips, trips, and falls. While these can occur year-round, certainly as we approach winter, slick conditions will increase their incidence. And anytime we have significant snow or even especially ice, we see a pretty significant increase in the number of orthopedic injuries, and most of those are due from slips, trips, and falls. It may be a simple bony injury, something as simple, to us at least, as simple as a wrist fracture, forearm fracture, a simple tibia or fibula or tib-fib fracture, or they may be very complicated, hip, pelvis, or complicated because of pre-existing medical conditions, and particularly blood thinners and other medications that the patients take. So these, while it may seem like a simple call to us, and may initially look like a simple call, there can be some complexities there that we ought to review. And then the overall big idea here is that the cause of the fall may actually be a serious thing. It may not just simply be that they slipped or they tripped that caused the fall. There may be a significant underlying medical cause for their fall, and that's where we kind of look a little deeper and give a little bit of added value to our patient, where we're not just responding to what is their chief concern and what's obvious, but we're looking behind and deeper and finding some of those things that really are what the patient needs us to look into. So let's explore that a little bit. What other things can cause a person to fall besides simply slipping on wet ground or tripping either over their own feet or a trip hazard? Maybe they had a fainting episode, a syncopal episode. Maybe they momentarily lost blood flow to their brain shut down, and that caused them to fall. Maybe that came from a transient ischemic attack or a TIA, which is essentially a stroke. It just clears in a short period of time. Maybe that TIA or stroke has caused them to have one-sided weakness and where they were unable to maintain their balance and they fell. Other more complicated things could be a cardiac rhythm problem. Perhaps they had an episode of VTAC or a short run of VFib, or they were extremely bradycardic, had a very slow heart rate due to some cardiac rhythm problem, and that caused them to decrease their cardiac output, decrease their perfusion to their brain, and they lost consciousness for that reason. Or it could be any of a number of the other altered mental status causes, and those, by the mnemonic AEIOU tips, alcohol, drugs, medications, a blood sugar issue. Maybe they had a seizure and that's what caused them to fall, and so even though we're called for a fall patient, it turns out to have been a seizure patient who fell. Maybe they're hypoxic. We certainly can't ignore hypoxia as a major cause of altered mental status. Maybe they had some head trauma, or they had something like a stroke or TIA or a bleed in their brain that caused them to fall. And so maybe they have injuries to their head that were caused by the fall, and the actual cause of the fall is something intracerebral or intracranial. Maybe they have a severe infection, and the P, of course, is psychiatric or fakers, and then the S being stroke. So just wanted to bring up again that the big idea here is that the cause of the fall in some cases will be a bigger deal than the injuries sustained from the fall, and we should be looking for those things. And in the few percent, the 4 or 5% of the time where that is the case, we shouldn't miss those. So even if the cause of the fall was simply slipping on wet ground or tripping, and it really was a slip or a trip that caused the fall, and the injuries may be, again, to us fairly minor, maybe just a wrist injury. Of course, to the patient that's not minor, but not a life-threatening large bone fracture. That doesn't mean that there aren't other things going on that can be a problem. Maybe the patient slipped, tripped, and fell outside in cold weather, and so now they have hypothermia on top of that. Maybe the patient had some alcohol involvement to start with, which is going to predispose them to hypothermia. Maybe they had some blood sugar issues to start with, and that predisposed them to falling, and then to also having trouble with hypothermia. And maybe they simply fell outside, it's very cold, and they've been shivering for a long time, and they've dropped their blood sugar because of that. So we have to tie all this together, and be certainly cognizant of the fact that as we get into very cold weather, a patient who has been down outside for a while may have some element of hypothermia. The other big thing on this is blood thinners. Many patients take blood thinners. They take aspirin in order to keep clots from forming, and they take medicines such as Coumadin or warfarin, very commonly prescribed. And if that fall caused a fracture or caused an injury that's causing some bleeding, that bleeding's not going to stop on its own as readily in these patients who are anticoagulated, in these patients who are taking a Coumadin or another blood thinner. So we need to be very careful that we identify those patients. There are many of them out there. Many patients who are at risk for stroke or at risk for heart attack will be taking a blood thinner as a preventive measure to keep away those life-threatening events. And ordinarily, unless they fall and hurt themselves, those medicines work very well for them and are an excellent thing for them to have. But unfortunately, if they do sustain some trauma, they do have a bleeding source, then those medicines can actually work against them. So we need to be careful during our sample history to identify those patients that are on blood thinners. The basics of managing the injury include an assessment of the injury, because in general we're going to splint these injuries as they lie. We're going to splint them as we find them. But part of our assessment is to check that injury and check distal from that injury to see if there is compromised circulation, motor function, or sensation. And we teach CMS. We don't use the PMS. And we teach CMS, C for circulation, whereas P stands for pulse. Because there's a lot more to assessing a person's circulation than simply trying to find a pulse. Pulses are difficult to find in some cases, particularly pedal pulses. We can assess circulation in other ways. We can assess circulation with capillary refill. We can assess circulation with skin temperature, with skin color. And we can add pulses to that as part of our circulatory assessment, and we shouldn't just call it PMS. We should talk about CMS. So check that distal CMS, see if they have evidence of circulation below or distal, away from the heart, distal to the injury site. See if they have decent circulation there by checking pulses, skin temperature, skin color, capillary refill. And then check for motor function and sensation. And we should compare side to side. We're very much a symmetrical being, and so we should check things side to side. Compare the patient's left foot that's on the injured leg side with their right foot that's on the non-injured leg side. Those feet should be the same. They should have the same color, the same temperature, the same motor function, the same sensation, the same pulses, usually. So a side-to-side comparison is particularly important. If they have a compromise in their circulation or their motor function or their sensation, we may well want to move that injured area. We may want to manipulate that extremity slightly, with the exception of knees and elbows. So if it's not a joint injury, if it's a long bone injury, if it's the injury is at the tib-fib area, and the foot on the injured side has compromised CMS, then we may want to try to bring that back into more of a normal position, or gently, carefully, minimally move that extremity just a little bit. That doesn't happen very often, but it's certainly something that we should be aware of. And in our situation, if you're in a first response role, that may be something you want to wait for the paramedic ambulance to make that determination. But that would be an important thing to include in your verbal handoff report to other responders, is that you do believe there's compromised CMS on the injured side, and they may elect to make a minor modification as they do the splinting to move that just a little bit. But for the most part, we're going to splint it where it lies. We're going to check the CMS beforehand. We're going to apply some sort of an appropriate splint that immobilizes the long bone above and below a joint, or immobilizes the joints above and below the long bone injury site, either way. And then we're going to check CMS again after we splint it to make sure that we didn't make it worse by whatever movement occurred as we place the splint. And we'll talk about splints here in a little bit, and they come in all various shapes and sizes. But splinting is our first and main treatment. Ice and elevation are not a bad idea as long as you can do that without compromising your splinting and without manipulating the area. Here's some example of upper extremity obvious deformities. Those are going to be painful. They're going to be swollen around the area of the deformity, and in many cases the deformity is very marked and easy to see. And wanted to point out that particularly in the case of upper extremities, if a patient has rings or other jewelry on, we would want to get that off. If there's going to be some swelling that occurs, we wouldn't want a ring to turn into a tourniquet essentially on the fingers. So distal to the injury even, we want to remove anything that might be a constricting problem. And then we're going to try to splint things, particularly in the bottom picture. You see what's called a Colles fracture. It's a fracture of both the radius and the ulna, the two bones of the forearm. We're going to want to splint that in the position of function. You see how the hand is draped over there rather than flat with the fingers extended. So general splinting rules, again, check distal CMS, compare side to side. Some ice and elevation would be great once that splint is applied. Check your CMS before you splint and then after you splint to see if you made it any worse. And remove any constricting items, particularly jewelry, and in this case rings, that are distal to the injury site. So on the previous screen we saw some distal upper extremity injuries that are fairly typical that patients sustain as they try to brace their fall. And these are also humerus injuries. Injuries to the upper part of the arm are not uncommon at all with falls. And here is an obvious midshaft humeral injury, and with quite a significant amount of bleeding that's occurring under the skin. Probably not a life-threatening amount, but as that bleeding occurs, there'll be significant pain, and we would like to limit the movement of those bone ends because there are vessels, blood vessels, that run next to those bones. There's a blood supply inside that bone. And we need to carefully limit the movement of that in an attempt to limit the amount of bleeding and swelling and impingement on nerves and such that's going on in there. Then I also wanted to point out down here at the bottom what is essentially a fracture in the elbow. It's a very distal humerus fracture, a distal humeral fracture. And any movement of that is going to be a bad idea and bad for your patient. The blood vessels and nerves to the lower arm are intertwined amongst that joint. And so manipulation of an elbow or a knee, and in this case we're talking about elbows, manipulation of that joint is a bad idea. And we need to be very careful to immobilize the humerus above and the radius and ulna below with probably a couple of SAM splints or a vacuum splint that does a very good job of encompassing that whole area and making for a rigid splint. These are the patients that wouldn't be at all surprised to have some compromised distal CMS as you compare the injured arm to the non-injured arm. You find a difference in capillary refill, a difference in temperature, a difference in color. Distal to that, would not be at all surprised to see compromised vascular flow, of compromised circulation from an elbow fracture. So as far as splinting goes on upper extremities, the mainstay is the sling and swath. A picture here, have a good video for you to also look at that's on our training website in the EMS section, and as well as an excellent video from the SAM Splint company that shows you all the various ways to make SAM splints. And I think it's probably something that we need to review frequently. A lot of us aren't aware of that it's more than simply cupping the SAM splint to make it rigid. There are some ways to make an I-beam, a T-beam. There's some ways to make these splints very, very effective, and it's well worth the 5 or 6 minutes of your time to review that SAM video. But again, the mainstay of our splinting that we have in a first response role with the fire district at least will be the sling and swath coupled with the SAM splint. So pretty much anytime you have an upper extremity injury, that's going to get a sling and swath. And a SAM splint in some manner, whether it's supporting the elbow or supporting the forearm and hand, to adequately splint that. And again, notice the position of function right here, where you don't have the fingers are not extended. The fingers are wrapped in some manner around that SAM. I find it helpful sometimes to put a roll of Kerlix in their hand so they have something to grip to the extent that they can grip. But it just keeps that hand from suffering further problems, and it promotes healing and mobilization down the road. Then from the transporting ambulance side, the vacuum splint, kind of a beanbag material that is easily molded around all kinds of strange deformities. You mold it around there while it's very soft and pliable, attach a vacuum pump to it, so vacuum the air out of it to where it becomes rigid, and they are very, very effective. And at this point, those are carried by the ambulance services in our system. So again, check distal CMS before and after splinting, and make a judgment call in the first response role, at least with the fire district, as to whether we're going to do the SAM splint, sling and swath, or if we're going to go with the vacuum splint, which should also be coupled with a sling and swath. One of the more common types of injuries that we see from falls are hip fractures. Hip fractures are very common in the elderly, and those folks really don't do well long term after those falls. So prevention is a key thing. Anytime we're in someone's home or in an area where we see possible trip hazards, we should certainly make note of that for the patient, offer to assist them with fixing that, because prevention of these falls is much more effective than an attempted treatment. However, a lot of these we can't prevent, and prevention fails, and so then we end up in treatment mode. Your hip fracture patient may have a shortened and externally rotated extremity. So again, the side-to-side comparison is important. Sometimes this is very subtle, sometimes it's very obvious and dramatic, as in this picture. A lot of those patients have a fracture through the femoral neck. The femur comes up and then has through the main part of the femur, and then makes this angle and fits into the ball and socket joint in the pelvis. It's through that angle, through that femoral neck, where a lot of these fractures occur. You can, of course, have a more mid-shaft femur fracture. You can have a fracture of the head of the femur as it fits into the joint in the pelvis called the acetabulum. You can have a fracture anywhere along through here, but very, very commonly we see these femoral neck fractures. These patients are tender in the groin area. They're very tender with any movement in any plane, either rotation or flex extend. Any movement of that injured extremity transmits a great deal of pain up to these patients. There's a fair amount of blood supply that runs through. That's a very large bone where a large amount of blood is produced, and there's a lot of vasculature and nerves around there. So hip fractures are very common for us, and they're probably not life-threatening in the field for most of our patients, but overall these patients don't do well, and we see this quite often in the elderly patient, the very patient who's more likely to have pre-existing medical conditions, take medications, particularly take blood thinners, and so a full assessment and full sample history on these patients is very important, as well as investigating the cause of the fall. The very same group of patients, your elderly folks that are more likely to have the hip fractures, are also more likely to have underlying medical conditions that may have caused the fall. So it's a very common call for us, and we can dig a little deeper than simply holding the patient still and not moving that leg until the transporting ambulance gets there. Just to be complete, I wanted to mention the acetabular fracture, as we said before, and here's that word. Acetabulum is the socket of the ball and socket joint of the hip. It is part of the pelvis. Typically, these fractures are going to occur with a fairly high force, such as in a motor vehicle crash, where the patient steps on the brakes, or other forces are transmitted up that femur and smash into that acetabulum. However, patients that do have some degenerative bone conditions and patients with brittle bones to start with can have some issues with acetabular fractures. So these patients should be very tender to palpation of the pelvis. If you were to push on the iliac crest or displace the iliac crest posteriorly gently, it won't take much force to elicit a pretty decent pain response in these people, and it would not be necessary to rock that pelvis. We want to limit the movement of these fractures as much as we possibly can. And so an acetabular fracture or a pelvic fracture can be something that we deal with our slips, trips, and fall patients. The last thing we wanted to talk about was how are we going to splint these? How are we going to move these patients? And so, you have options of scoop stretchers, the metal scoop stretcher that will lengthen and in theory can be placed under the patient in some cases to carefully pick them up. I think we find that in a lot of situations there's as much or more movement by application of that scoop as there would have been had we not used it. But it's there as a tool, not carried on fire district apparatus, but available on the ambulances. Almost always carried in an outside compartment, so it's exposed to cold temperatures, and it's certainly not an insignificant thing to think about the discomfort to your patient and the potential for conductive heat loss to that very, very cold scoop stretcher. And then if you add blankets in an effort to insulate the scoop stretcher, it just tends to make the scoop even harder and harder to use. Now there's a newer type of scoop out there called the Combi Carrier, and there's probably other brand names. That's the one I'm familiar with. And it splits as shown there. It splits differently than the standard scoop. And the idea in this is that it's a scoop stretcher and long spine board in combination. And so we may run into those in the transporting service. We don't have any on the fire district. They're pretty pricey right now, and it's not altogether proven that they're going to be of any more benefit than a standard scoop or a standard backboard. And then there's the mainstay of most of our splinting. Certainly it's the splint of choice for any unstable patient. It's the splint of choice for patients with spine injury. And it's useful in moving other patients, and particularly hip patients, cardiac arrest patients, those type of patients. And you may be able to get a decent, safe move for you and for the patient with the use of that spine board. If there's a way to move the patient without subjecting them to the movement onto the spine board, if there's a way to move that patient with blankets or in the patient pictured maybe with some sheets from the bedding, with a number of personnel in a very slow, deliberate move, that's acceptable. Remember, the goal here is not to mobilize the spine. The goal is to mobilize the hip. And so if we can use pillows, if we can use blankets, if we can use whatever we have and whatever is available at the scene to limit the movement of that hip, pelvis, and leg, then we've accomplished the goal. Sometimes that's a backboard, sometimes that's a scoop, sometimes not. So a fair amount of judgment comes into this. Probably a good plan would be to take into account opinions from all the EMS providers on scene. And in many cases, at least in the first response role that the fire district plays at this point, in many cases we're going to wait for the transporting ambulance both to have some additional hands as well as to have the destination, because the patient should be moved as few times as possible, and the objective is to move them to the ambulance cart. So we'll need to wait for the ambulance cart. So something to practice at the station level, practice whenever you can and wherever you can, and have a great deal of empathy for these folks, because not only does this hurt them a lot, but we're moving bones around in there that are in close contact with nerves, blood vessels, and so in addition to blood supply, we can make things a little bit worse with the bleeding. So kind of to wrap up, slips, trips, and falls, very common that we see them year-round. More common as we start to see slick conditions, which we'll be encountering here. And so the assessment involves looking deeper than simply the injury, looking for the cause of the fall. Maybe it was simply a slip or a trip, but looking deeper for the cause of the fall, finding those patients that have underlying medical conditions, finding those patients that are taking blood thinners that may increase the bleeding from what would be a relatively uncomplicated fracture, and then doing some good fracture management, doing some good circulation, motor, and sensation assessment distally, both before and after the splinting, and doing things with moving hips and immobilizing wrists and arms and elbows, and using slings and swath and SAM splints and backboards and all these sorts of things. So just wanted to bring this up as an overview, encourage review of this, encourage practice of this, and in anticipation of us seeing more slips, trips, and falls.